Okay, so you were lured to this talk by a broad title, Update on Women's Health Prevention. We're going to focus on breast and cervical cancer screening. I hope that's okay with everybody. I have nothing to disclose. And so what our agenda is going to be is I'm going to start by talking about different screening recommendations, breast cancer screening in women. As we all know, there are lots of different recommendations. It makes it very complicated and confusing for both our patients as well as ourselves. We're going to briefly talk about how to evaluate a woman's breast cancer risk and how that should be pulled into the conversation. Then I'm going to talk about updated cervical cancer screening guidelines. Then I'm going to pass it over to Gale. We're going to watch a short video, and she's going to talk about goals and accomplishments of the Wisconsin Well Woman program. And at the end, we hope to have 10 to 15 minutes for questions. So as Mary said, if you have questions, just put them in the chat. We will try to get to them at the end. And I apologize in advance. As you can see, it's a very ambitious agenda, so I'm going to talk pretty fast. So I apologize if you missed something. Okay, so why do we screen for breast cancer? There's pretty good evidence that mammograms save lives from breast cancer. The lives saved are, it's a modest light savings of life, but they're definitely, we save lives. We also detect breast cancers at an earlier stage, meaning that women can have less invasive procedures and less further treatment. I think part of the complication and the controversy is at what cost, and who is making that decision, right? We look at things at a population level, but then looking at single women one by one, it's hard to interpret sometimes. So mammograms are not completely benign. They can have false positives, which are more common in women under 50. False positives means that people come back for extra views. Those would be unnecessary tests, even sometimes biopsies. These false positives can cause long-standing anxiety. And I've been in multiple meetings with specialists who sort of roll their eyes, especially the surgeons. They roll their eyes and they say, well, it was a negative biopsy. What's the big deal? But some studies have shown that anxiety after you have a biopsy, even if it is negative, can last 12 to 18 months. And it's real. Doing mammograms, going and looking for cancers, that will find small cancers that maybe wouldn't be clinically apparent or have clinical impact if you just left them alone and didn't know you had them. Mammograms, there has not been an improvement in the technology, and they still cause pain and discomfort. And this is one reason that people don't like to get mammograms. Insurance issues is, this is a new thing that I have found recently. I've had several patients get called back for extra views, and then the extra views aren't paid for because they're billed as diagnostic instead of screening. If somebody wants to do some advocacy, this would be a great place to do advocacy, because it's terrible. People then get a big bill for a diagnostic service that they wouldn't have had if we hadn't encouraged them to do screening. So I like this table. It's a little busy, but this is for women 50 years or older. And most of the controversy is really in the younger women, the women between 40 and 49. But even in women 50 and older, if you look at this, 1,000 women who aren't screened, 5 are going to die from breast cancer in 10 years. 1,000 women who are screened, 4 are going to die from breast cancer. So in 1,000 women getting routine mammograms, you're going to save 1 life. And then if you kind of look down at the harms, 100 of those women are going to have false positives. 5 are going to be what we call overdiagnosed, meaning we found cancers that wouldn't have been clinically relevant. Okay, so this is sort of a question in your heads. I want you to answer, like, what screening recommendations do you follow? Because there are a lot of them, and they are all different. I'm going to go through all of these, and then we'll talk at the end about how we make sense from conflicting recommendations. So all of these recommendations are based on the same data. So really smart people looked at all of the data and came up with varying recommendations. And this is partly why it's so complicated, right? Because you can't say this one's right and this one's wrong. There are lots of shades of right and lots of shades of maybe not the best idea. Okay. So sorry. Okay, so the U.S. Preventive Services, this is sort of wordy, but I put it up here for a reason. So U.S. Preventive Services is pretty clear. They recommend biennial mammography screening from women age 50 to 74. That's a B recommendation. So women 40 to 49. Part of the reason I put this slide up here like this, because you look at it and you're like, wow, that's a really busy slide. There aren't many other U.S. Preventive Services recommendations that have so many words, right? That's so complicated, they say, but in this case, and they basically say the decision to start screening mammography in women under age 50 is an individual one. For women who are average risk, most of the benefit of mammography results from every other year screening from 50 to 74. While screening mammography in women aged 40 to 49 may reduce the risk of breast cancer death, the number of deaths averted is smaller than that in older women, and the number of false positive results and unnecessary biopsy is larger. The balance of benefits and harms is likely to improve as women move from their early to late 40s. They also say that beginning mammography screening at a younger age, screening more frequently may increase the risk for overdiagnosis and subsequent overtreatment. These recommendations are from 2016. They are currently updating them, so stay tuned for whether there will be more specific but less complicated recommendations. In addition, this is also 2016, just as a sort of adjunct. U.S. Preventive Services concluded that there was insufficient evidence to recommend digital breast tomosynthesis, which, as you know, is like a three-dimensional mammogram that most health systems in Madison are using. They also concluded that there's not enough evidence to do adjunct screening for women with dense breasts. And in the news frequently are, legislations saying that everybody needs to be informed that if they have dense breasts. What we do with that once they get the letter and come to us and say, I got a letter saying that I have dense breasts, is unclear. And then for women age 75 or older, again, U.S. Preventive Services says there's insufficient evidence to come up with a broad recommendation. Most people will rely on the U.S. Preventive Services as the most objective, evidence-based, and unbiased. And I'm not saying bias in a judgy kind of way, but if you look at some of these other recommendations, like from the American Cancer Society, American College of Radiology, they have sort of underlying biases that, it's all not judging them, but it's all based on trying to help women and do what's best for our patients, but doesn't always take into account the fact that people may have differing beliefs and differing motivations. So American Cancer Society, this is also from 2015. They say start at 40, go to 44, and those people have the option to start screening. But once you hit 45, you should get a mammogram every year until you're 54. When you're 55, you can go to every other year. And you should keep screening as long as you're in good health and expected to live more than 10 years. And then at the end, they say all women should understand what to expect when getting a mammogram, what the test can and cannot do. All right, so that's American Cancer Society. ACOG, I don't understand why they felt the need to come up with yet another recommendation, but they say offer screening mammogram at age 40. You shouldn't do it before age 40. And And if you haven't started by 40, you should begin screening mammography no later than 50. And you should have a shared decision-making discussion. You should do it every 1 to 2 years based on your informed shared decision-making process. And then go to every other year at 55. And they say you should continue screening until you are 75. Okay, National Comprehensive Cancer Network. So this was from 2022. They say most women with average risk should get screened every year, beginning at age 40. But if there are additional risk factors, you can even start earlier. You should start a risk assessment at 25. And they say beginning annual mammograms at age 40 is associated with the highest mortality reduction for average risk women. And you notice there is not a caveat there saying, but also includes the highest rate of false positives and overdiagnosis. American College of Physicians, we normally think about them as pretty evidence-based, and they're very close to the U.S. Preventive Services. But they do say that, you should talk about risks and benefits with your clinician, personal preferences, if you want to start screening before the age of 50. American College of Radiology and the Society for Breast Imaging, this was from 2021. They say start at 40, go every year with no upper limit. And they also say, and I always find this, they kind of shame people who don't screen. They say women who wish to maximize benefit will choose annual screening starting at age 40 and will not stop screening prematurely. Okay, so here's a visual, because I like visuals. This is the American College of Radiology. They say do a risk assessment at age 30, annual mammograms starting at 40. Screening should continue past age 74 and no upper limit unless there are severe comorbidities. And then at the end, they do say, you should certainly think about the possible for additional imaging, benign biopsies, risks of anxiety, and overdiagnosis. So, wow, that's a lot, right? And there are similarities, but there's a lot of conflicting information. My patients come in and they say, well, what do you recommend? And that's one of those, like, metaphorically put your pen down and lean back in your chair and say, well, it's complicated, right? Because these are all very smart people, used the same data and came up with really pretty different recommendations. I think this is really a time that we want to focus on individual decision making. We want to do a risk assessment for our patients because most of these recommendations focus on women who are average risk. So we at least want to pull out women who are at high risk. We want to do some patient education, and we want to do shared decision making and include patient values. My discussion with somebody who's had a false positive is very different than my discussion with somebody who has a family history versus somebody who has other health issues. So this is where the individual shared decision making is going to come in. I'm not going to talk a lot about shared decision making, but just a plug, we do have lots of resources available on our DFMCH website if you're interested in learning more about shared decision making and breast cancer screening. So like I said, all recommendations are for average risk women. Why should we assess risk? I think ultimately it's to support women making an individualized decision about whether or not and how often to do mammography screening. Based on their risk factor, women may make different choices. Ultimately as well, if people are determined to be high risk, they may qualify for enhanced screening or chemoprophylaxis. It may determine whether doing genetic testing is appropriate. And it also may determine whether we should refer them for enhanced screening if they're at high risk. So how to assess risk? Some of it's history. Some of these things we should trigger something in our heads, right? Somebody who's had past ovarian or breast cancer, someone who's had chest radiation, someone who has a family history or a family member with positive genetic testing. somebody who's had an atypical breast biopsy. There are different risk models. Most people have heard of the Gale model. It's been around for the longest time. It's quick, but leaves out, it's maybe not as accurate as some of these other models. Some people use the Breast Cancer Surveillance Consortium model, the BCSC. I have been using the Tyrer-Cuzick or the IBIS model because it can pull in density if you've had a mammogram. It also can pull in a more comprehensive family history. So the Gale model just includes first-degree relatives, while the Tyrer-Cuzick model includes second-degree relatives as well. Because of that, it may be a little bit more accurate. And some of the guidelines about enhanced screening and chemoprophylaxis will designate which model to use. Now, the more detailed model takes longer. At this point, we do not have an embedded risk model in our EPIC, but I did give this talk at a residency in Chicago, and Advocate Aurora does. So it's definitely possible to have that, which would be great because some of the data would auto-populate. Okay, so 20% lifetime risk is categorized as high risk in the United States. Apparently in Canada, it's 25%, but if you meet that risk, you are eligible for enhanced screening as well as chemoprophylaxis. And recommendations are to reassess every 5 years or if something new happens. So enhanced screening includes MRI and yearly mammograms. For people with moderate risk gene variants, MRI screenings start at age 40 with BRCA1 or 2 mutations. Much more intensive screening with MRIs starting at 25 and discussion of, risk reducing mammography. Medication, both tamoxifen or aromatase inhibitors are approved for chemoprophylaxis and can 5 years of either of these medications can significantly decrease your risk of getting breast cancer. So I see our role as women's advocates to help sort through the data, give clear guidance about individual risk status, and provide a roadmap to help women develop their individual screening plans. And it's a conversation that may change over the years and that I tend to have routinely with women when they come in for their well exams. Okay, I'm quickly going to switch gears and just do a quick update on cervical cancer screening. There are a couple new things with cervical cancer. Just the statistics from 2020. In 2020, there were almost 14,000 women in the US diagnosed with cervical cancer, and about 4,200, almost 4,300 died. I think this next bullet is really the key. The lifetime risk is 3.7% in unscreened women versus 0.3% in screened women. In our practices, we tend to spend a lot of time focused on these 0.3% with our, LSIL, ASCIS, and having people come back. And these are really not the women who are having, who are getting cervical cancer and dying from cervical cancer. It's the people that aren't getting screened. And that if we would make the most impact by trying to increase the number of people who are going to get screened. And I know Gale will talk about that too. So pap smears were, when they were developed in the 40s, it's one of the most effective public health interventions in the United States. Incidence of cervical cancer decreased by almost 80% between the 40s and the early 2000s. The rates have been constant for the past 20 years or so, and that's mostly because there are still a significant number of women not getting screened. So who gets cervical cancer? So people who are not screened, it's very, very, very rare in women under 25, which is why a lot of the new recommendations are, less aggressive about abnormal pap smears in women under 25. Worldwide, cervical cancer is the second most common cancer in women, with 500,000 new cases every year and 240,000 deaths each year, most likely due to decreased access to screening. So cervical cancer is a little bit of a different kind of situation in that it is caused by HPV. Like 95+% of all cervical cancer is caused by HPV infection. And young women, this is part of the reason why young women don't get cervical cancer, even when they have abnormal pap smears. They can clear the virus. So in adolescence, the average time to clear an HPV infection is 13 months, and the majority clear the virus within 2 years. In women over 30, HPV infection is more consistent as a persistent infection and a more powerful risk factor for cervical cancer. So most HPV infections that lead to cancer are acquired before age 30. HPV vaccination, which we are still not so great at, can prevent 85% of these infections and theoretically 85% of cancers. The majority of precancer or CIN3 develops between ages 25 and 35, and that's really the goal of screening, is to detect precancer. Cancer rates begin to rise at age 40 and continue to increase with age in an unscreened population. And then screening should end when a woman's lifetime risk falls below agreed upon thresholds, and we'll talk about that in a second. So little less controversy. This is U.S. Preventive Services in breast and cervical cancer screening. They say that an A recommendation, and there aren't a lot of A recommendations, but A recommendations, so cervical cytology alone in women age 21 to 29. Remember, we used to start screening at 18, no longer. For women age 30 to 65, they recommend screening every 3 years with cytology every 5 years with high-risk HPV testing alone, or every 5 years with co-testing, which is cytology plus HPV. They're also pretty clear that you should stop screening at age 65, even when and if a woman has a new sexual partner. The physiologic changes of the cells of the cervix make those cells less susceptible to HPV, and the progression of an abnormal pap smear lesion is so slow that a woman, most likely will have died from her stroke or MI before she would develop cervical cancer. We shouldn't screen in women younger than 21, and we should stop screening in people who've had a hysterectomy with removal of the cervix. So just to recap, 21 to 30, do cytology alone every 3 years. You can do a reflex. So if you have an abnormal pap smear, you can do a reflex HPV. But we really discourage doing co-testing, meaning HPV plus cytology in this age group, because the prevalence of HPV is so high that you're just going to get tons of positives, and then you're going to be like, oh, why did I do that? And then you get sucked into this increased frequency of screening. So do not do co-testing. Age 30 to 65, there are 3 options. You could do cytology alone every 3 years if you don't have access to an HPV test. You can do an FDA-approved primary high-risk HPV testing alone. As of the last time I checked, we do not have access to that particular test at UW Health. Or you can do co-testing, which is cytology plus high-risk HPV every 5 years. In 2019, ASCCP updated their guidelines for management of abnormal pap smears, and their goal was to achieve simplicity and precision. And a lot of their recommendations are focused on a woman's risk of developing CIN3. And the clinical actions that they recommend are based on individual risks. So just as an example, if your pap smear shows normal or ascus and you have a negative HPV, your 5-year risk of a CIN3 or greater is less than 1%, which is why, you can go and extend screening. You do not need to do more frequent screening. If you have ascus, but we don't know the HPV, your risk is 3 to 4%. And ascus with a positive HPV, you're 7 to 8%. ELSIL, you can see. And High-grade lesions, you have 50% 5-year risk of CIN3 or greater. The ASCCP has set a cutoff of 4% 5-year risk as where they recommend colposcopy. So if you look at these cutoffs, you know, most of these we're doing colposcopy for these abnormal pap smears. Okay. That is all. I told you I was gonna be really fast. Let's go to Gale. And Matt, do you have the video? Awesome.
Milwaukee has a great need for breast cancer screenings.
One of the things that women that we serve struggle with is health literacy.
I think they understand the need to health care, but I think one of the problems is that they have so many other things going on in their lives that the last thing that's on a person's mind when they have those kind of situations is health care.
It's important for the state health department, for the Well Women program, to work with individuals who are already engaged, who have established trust, who can help bridge that alliance and ensure that it is implemented, you know, in a fashion that's convenient, not only for the agency, but more importantly for the community as well.
Every Saturday, we have at least 3 to 4 programs going where we're in the community somewhere, at a church, we're at an apartment complex, we go to homeless shelters, we go to the homeless clinics, we go to drug rehab centers, trying to encourage as many women as we possibly can how important it is to go ahead and have the screening done.
It just takes a moment, in some instances, to stop and just to listen.
The driving factor behind creating this establishment was making sure that Native Americans always had a place to go where they would feel like they were getting their medical services with dignity, because they weren't always getting that in the regular medical system.
We don't trust the healthcare system because no one has really made the time to help us understand it. And so that's where we feel that the Milwaukee Consortium for Hmong Health is playing a very, very important role.
My role is being a bridge. I'm able to work with my Karenni community because I'm from there. I know culture. She's saying that I cannot speak the language and I don't know how to make the appointment on my own, so I was going to call you to help me with that.
Many of us have been touched by different types of historical trauma that has affected the way that we have, you know, formed our medical opinions. Hopefully, Pink Shawl's work will help kind of break that cycle.
When we were educated that regular screening so that the doctors can catch it early and help us, it can save a lot of our lives. You know, it makes perfect sense for us to, you know, pursue this to bring more education to the community.
I just can't thank this program enough. It gives me a sense of satisfaction knowing that I'm saving lives, one mammogram at a time.
If we are committed to serve the community and honestly respond to those needs that we can easily address, we can affect a mighty change.
Good afternoon. Can you all hear me okay?
Yes.
Okay. Good afternoon. Good afternoon. Good afternoon. I'm Gale Johnson, the director of the Wisconsin Well Woman Program. And as we said, the Wisconsin Well Woman Program is CDC's Wisconsin component of their National Breast and Cervical Cancer Early Detection Program. So a little bit of history about that video. The original legislation, Public Law 101-354, was signed in 1991 by then the first President George Bush. In 2021, the national program celebrated its 30th year anniversary. 6 programs across the state, across the country, were awarded, were asked to participate in the anniversary video, and Wisconsin was one of the awardees. So I'm very proud of that, because you got a little bit of a chance to see just some of the folks that we work with and some of the organizations. So to tell you a little bit more about the program, Dr. Schrager talked about, insurance issues and complications. Well, our program exists because prior to 1991, there were women across the country who were dying needlessly from breast and, unfortunately, some cervical cancers. Why? Because they had low incomes, they had no insurance, they had no access to screening services. So the one thing that we are able to do is to work with women with low incomes who have no insurance. And by the way, the other point that Dr. Schrager talked about was, the additional cost, out-of-pocket cost for certain diagnostic procedures. We're also able not only to work with women who are uninsured, but we also work with women who may be underinsured. That is, they may have a copayment or a deductible that does not necessarily allow them to pay for the diagnostics, screening services, diagnostic services, or other services. Our focus is on women in their middle years. We mostly see women who are between the ages of 45 and 64. So next slide, please. Next slide. Okay. We primarily provide services to women who are between the ages of 45 and 64. We do provide services to women as young as 35. Generally speaking, if a woman is 35 or 36 and she has a problem and her clinician says, I think you need, to have a screening service, especially when it comes to mammography, we will provide that service. We also, and this is the other age group that sometimes we don't think about, we also provide services to women who are over the age of 65 if they are not eligible for Medicare or they cannot afford Medicare Part B. Our income guidelines are at or below 250% of the federal poverty guidelines. And so just to give you an idea of what that is, if you are a household of one person, that's probably somewhere in the neighborhood of about $34,000, $35,000 a year as your income. So the question we get all the time is, well, how do women enroll in the program? Next slide, please. They enroll in the program through our coordinating agencies, and I'll talk about the coordinating agencies in just a moment. I wanted to let you know that the Wisconsin Well Woman Program has been providing services since 1994. And in that time, of course, we have provided services to more than 83,000 women across Wisconsin. And that amounts to well over, almost 600,000. I think if I went to my data manager in the next couple of minutes, we're probably at 6,000 at this point. During our last program year, which ended June of 2022, we provided services to just a little bit more than 3,600 women. Next slide, please. So I'm going to talk a little bit about the coordinating agencies, because again, the question we get all the time is, well, how do women enroll in the Wisconsin Well Woman Program? We have coordinating agencies throughout Wisconsin who are serving the 72 counties. Now, for the most part, our coordinating agencies are local health departments. We do have a couple of exceptions. ProHealth Incorporated, which is a large health system in the Waukesha County area, their Hispanic Health Resource Center is actually our coordinating agency in Waukesha and Jefferson counties. Then we have the City of Milwaukee Health Department, and the City of Milwaukee Health Department is both a coordinating agency and a provider site. So not only do they enroll you, they can provide your initial Pap test. They can also refer you to one of our other providers in the Milwaukee area. They also do screening mammograms. And then, of course, you see our other coordinating agencies. And just to let you know, Each coordinating agency, except for the city of Milwaukee, can be responsible for anywhere from 2 counties up to 10 counties. But most of the coordinating agencies are probably somewhere in probably the 3, 4, 5 counties that they're responsible for. Next slide, please. So the coordinating agencies, what is it that they do? As we said, they do enroll you in the program. And what they do is they work with you to determine your eligibility. Are you, within our age range? Are you within our income guidelines? Do you have insurance? And again, if you have insurance, you're still within our age guidelines and your income is still within our income guidelines, you can still enroll in the program, because remember, we may be able to help you with co-payments and deductibles, even if your insurance covers your initial screenings. The coordinating agencies also do what we call case management. Every woman who is enrolled in the Well Woman program and who gets services, we have to know what provider she went to, and it has to be a Well Woman provider. We have to know the outcome of that screening service. We have to know, does she need diagnostic services? And we also have to know whether or not there was a diagnosis of treatment. And part of the case management responsibility of the coordinating agency is to make sure that treatment is initiated in a timely fashion. The coordinating agencies also support the providers in their community. A lot of times, especially with your larger health systems, the coordinating agency might even actually make the appointment for the client. And so and we have coordinators who are part of our coordinating agencies who actually meet periodically with the providers in their area to share, updates on how things are going and all of that. The coordinating agencies, and this is the other thing that's very important, they are also responsible for outreach and education in their local communities. And why? Because we feel like they know the communities best. They know where to go when it comes to, holding education and outreach kinds of activities. Next slide, please. So we also work with 11 tribal nations right here in Wisconsin, and this is a list of those agencies. They are also coordinating agencies for their tribal members. So we work with them. Now, I will tell you, again, one of the things that is interesting about working with the tribal nations is we don't necessarily screen as many women from the tribal nations, but what is really important is talking with women, again, about the importance of breast and cervical cancer screening. So if you're eligible for Well Woman, fine. If you're not eligible for Well Woman, you have your own insurance, that's okay too. A big part of our job is the education and outreach. Next slide, please. We have a provider network of about 41 provider organizations across the state. If you are enrolled in the Wisconsin Well Woman program, you can really go to any one of our provider organizations. Most of our clients choose to go to provider organizations who are fairly close to where they live. So our provider organizations include health systems, the federally qualified health centers, rural health clinics, and hospital outpatient clinics. And when it comes to these 41 provider organizations, because many of them have multiple sites, just like the UW, we are looking at more than 450 clinic sites that are accessible for breast and cervical cancer screening through the Wisconsin Well Woman program. Next slide, please. Another very important component of the Wisconsin Well Woman program is our patient navigation component. And one of the things that is so important about our patient navigation is that it is individualized assistance offered to women to help them overcome barriers to breast and cervical cancer screening, diagnostic services, and again, making sure that they're able to get treatment. women who receive our patient navigation services they may have private health insurance. And I think if you all think about when the ACA legislation came into being, and folks, there were people who we know got insurance for the first time in many, many years. They had the insurance, but they didn't necessarily know, okay, how do I work through the healthcare, the health insurance landscape? So our patient navigators are able to work with women who have private health insurance, women who have Medicaid, women who have Medicare, because again, there may be questions they might have. There may be situations where, well, since I don't know what to do, I'm not going to do anything. That's where the patient navigators come in. Next slide, please. So we have the patient navigation locations in 3 places here in Wisconsin. We actually started with Marshfield Clinic in 2010. And in the spirit of full disclosure, Lena Sutton just recently left Marshfield Clinic. And so we are in the process of getting a new patient navigator with Marshfield Clinic. But we started with Marshfield Clinic. And Marshfield Clinic is responsible for providing patient navigation in central, western, and northern counties. And the focus, quite frankly, is on women living in rural areas. Dawn Shelton Williams is our patient navigator with Advocate Aurora. And she's responsible for, of course, Milwaukee, Kenosha, Racine, and Waukesha counties. We also have Ana Karina Celia Montes, who is actually the patient navigator with the UW Breast Center. And Ana Karina obviously is responsible for about 16 counties in Wisconsin's southern region. And the question I get asked all the time is, well, you have patient navigators in 3 regions, and there are 5 public health regions in Wisconsin. Are you going to have additional patient navigators? And I always say, yes, when we win the lottery, okay? Because we have found that it does make a difference. It is absolutely wonderful to have someone that women can go to one-on-one to talk about challenges that they may be having in terms of accessing breast and cervical cancer screening, and as I pointed out, even initiating treatment if that's necessary. Next slide, please. The Wisconsin Well Woman Program has worked with the National Association of Chronic Disease Directors. They approached us in 2020. Well, actually, they approached us a little bit about 6 months or so before the pandemic. They had a project called Using Data to Reduce Breast Cancer Disparities, and Wisconsin was one of the states chosen to be a part of this particular project. Next slide. With respect to the Reducing Breast Cancer Disparities project, we all know that breast cancer is the second most common cancer and the second leading cause of cancer death in women. One of the reasons that the National Association of Chronic Disease Directors asked Wisconsin to be a part of this project is because Black women in Wisconsin continue to have higher death rates when compared to women from other communities when it comes to breast cancer. So part of the project, a big part of the project, was using Wisconsin's data to really help to reduce breast cancer disparities and disparities in mortality rates, taking a look at the data. So one of the things that we said we were going to do was to create data products here in Wisconsin. Next slide, please. Next slide, please. Okay. I will come back to this in a minute, so next slide. With respect to the Reducing Breast Cancer Disparities Project, the National Association of Chronic Disease Directors actually asked 3 states to participate in the project. Wisconsin, as I said, was one, but Mississippi and Tennessee were the other 2 states. Again, they looked at breast cancer morbidity and mortality in Wisconsin, Mississippi, and Tennessee and said, we'd like to work with you. And of course, we said yes. Next slide, please. One of the things that happened with this project was in August of 2019, we had a community engagement meeting in Milwaukee. And what we did, we invited African American women who had been impacted by breast cancer. We had women there who were going through treatment. We had women who were long-term survivors. We had women there where we had the mother and the daughter attend the meeting. We had women who had lost loved ones to breast cancer. We had standing room only because we wanted to hear from the community. What do you think? What are you seeing? The first thing that came up was, we're seeing breast cancer deaths in younger women in the African American community. So one of the things that we did in terms of our data products and working with data is we formed a data committee as part of our Reducing Breast Cancer Disparities leadership team. And the data committee worked on looking at Wisconsin's data with respect to breast cancer disparities between Black and white women. And the initial report, was released this past October. And one thing I forgot to do was to put the website for getting the report if you're interested in getting it. But if you go to the Wisconsin Cancer Collaborative, they're one of our partners. The information for the report is on their website. So the report has been released and it's being circulated. Folks are taking a look at it. The other thing that we're planning to do is to have a follow-up community engagement meeting sometime this summer to talk about the report, to talk about some of the other data products that we're putting together, and just to kind of see where folks are, to see what else we need to do. Next slide, please. These are the acknowledgements. These are the individuals who are part of the Reducing Breast Cancer Disparities leadership team. I'd like to point out Dr. Sandra Millen Underwood is our chair, but I also like to point out that Dr. Sandra Millen Underwood was just appointed to the U.S. Preventative Task Force I'd say about 2 months ago. So just wanted you to know that we have a Wisconsin connection on the task force. Next slide, please. With respect to the Wisconsin Well Woman Program, one of our major partners is the Wisconsin Women's Health Foundation. So if you need information on where can I go to get a mammogram at no charge, where do I find out about the Wisconsin Well Woman Program, you can go to the Well Badger Resource Center. You can go to their site. You can call their phone number. Not only do they have information on the Wisconsin Well Woman Program, they also have information on other resources that you might need. As this slide indicates, you know, families, adolescents, children, health professionals, and others. One other thing that I would like to just share with you, and I did forget to put this in a slide. Dr. Schrager talked about a lot about cervical cancer. The Wisconsin Well Woman Program and the Wisconsin Immunization Program have been partnering on Cervical Health Awareness Month, which of course is every January, probably for 6 or 7 years. We did get interrupted due to the pandemic, but we are in the process now of putting together a campaign for Mother's Day, where we are going to talk with the mothers, the godmothers, the aunts, the grandmothers of young people. Number one, about the importance of cervical cancer screening, okay? But number two, and this is really where the mothers, the guardians, and everybody, where they come in, we're gonna talk about the importance of the HPV vaccine. So stay tuned for that. Next slide, please. Let me just say this before I close. We have a lot of partners with the Wisconsin Well Woman Program. We could not do half of what we do if we didn't have great program partners. So just wanted you to know that. Thank you for listening to me, and enjoy the rest of your day.